Hey guys, welcome back to SD3 Hacks, and today we're going to be discussing the prosthetic joint infections. Just a few housekeeping points. If you haven't checked out my website, it's aniketbharadwaj.com. It has a lot of free guidance and resources for how I approach the interview, along with options to get my cheat sheets and sign up to interview practice if any of you want some last-minute grilling. Now, moving on to the episode, we're going to talk about the prosthetic joint infection specifically, and we're going to cover the MSIS or MSIS criteria for diagnoses, the timeline of infections, the critical decision making between a DAIR and a revision. This was quite complex for me, and getting the decision right changes literally everything about the management. So let's move on to definitions and pathoanatomy. A prosthetic joint infection is an infection of a prosthetic implant. It's different from septic arthritis of a native joint because an implant really changes the game. The bacteria can form a biofilm on the implant surface, which is basically a community of bacteria that stick onto the implant under a glycocalyx, evading the host immune system and basically making antibiotics useless. Once this biofilm develops, you can't sterilize the joint with antibiotics alone, and you have to remove the implant. But here the timeline is really critical. So infections within 6 weeks of surgery are acute, and biofilms usually haven't developed yet. And this means that you can potentially treat it with a DAIR. Now, early on in my core training, people used to mention this term and I had no clue what it was, but it basically stands for debridement, antibiotics, irrigation, and retention of the implant, with removal of exchangeable components like the liner. After 6 weeks, the biofilm has developed and a DAIR won't work, so you need a revision, removing all the implants and potentially doing a staged exchange. Now, the important differentiation point here is that in your prioritization station, if you get a patient with a prosthetic joint infection, you can comment on the timeline being really important, as that would indicate whether it just needs a DAIR, which most consultant surgeons can do, or does it need a comprehensive revision in case you need a specialist surgeon, i.e. lower limb knee surgeon, for example, for that. And that kind of shows lateral thinking and is a golden pearl differentiator. Coming back to the station, the organisms matter. You've got the Staphylococcus aureus, which is, the obvious common and aggressive organism that we all know. Then you've got coagulase negative staphylococci like Staph epidermidis, which is a bit more insidious. They're lower virulence, but they form a biofilm really easily. That's why you need to understand the timeline. A patient with Staph epidermidis infection at 3 weeks post-op might get a DAIR. The same organism at 3 months may need post-op revision. Okay, so that's your kind of differentiator. Now, diagnoses. Here you use something called the MSIS criteria. This is the Musculoskeletal Infection Society criteria that helps you diagnose PJI systematically. The criteria have major and minor categories. If you have either of the 2 major criteria or 6 points on the minor criteria, you diagnose the infection. So let's go through them slowly. The major criteria: 2 positive periprosthetic joint cultures with the same organism, or a sinus tract communicating with the joint. That's it. Those are your unambiguous kind of findings. Minor criteria. There are quite a few of these. So serum markers: high CRP, high ESR, that's 2 points. Synovial markers: high white cell count, high CRP, high percentage of polymorphonuclear cells, or positive alpha defensin, that's 4 points. So if you get 2 positive synovial markers, you've already hit your threshold for diagnoses. The point here is that PJI diagnoses is multifactorial. You don't need just a positive culture. It's the combination of clinical presentations, your inflammatory markers, your synovial fluid analysis, and you check your synovial white cells and your alpha defensin. Moving on to our triple assessment. So you start with a history. Here you should say something like, I take a relevant post-operative history, understand the indication for the initial surgery, and whether they've had any previous infections. Operative details that you want to know is time, location, surgeon, implant, operative notes. I think someone said previously like why, when, where, and by who. That's a good one as well. Moving on to the examination, I'd do a thorough look, feel, move assessment along with a neurovascular assessment. I'd want to inspect the wound with concern for discharge, checking if it's pus, clear fluid, hemoserous. I would review their drug chart to check if they have recently started back on any anticoagulants. In investigations, I'd ensure to get a CRP ESR along with all the trauma bloods. They're usually elevated in infection, but can be suppressed if the patient has already been on antibiotics. I'd get plain x-rays, AP and laterals to look for implant loosening, which may suggest infection. Loosening doesn't prove it, but it's a red flag. And I'd look for any periosteal reactions, bone loss, or any other signs of chronic process. The BOAST PJI guidelines also mention nuclear medicine scans that can have a strong negative predictor value. If the scan is normal, the infection is less likely. This is a very niche point, and I don't think many people would mention it in the acute setting, but it's something if you can remember, you can drop it in. Moving on to management. So you'd only give antibiotics if the patient is in sepsis, and then you'd only consider an acute washout, say overnight or the next day, if they are really unwell. And you wash them out, debride them as a temporizing measure to allow patients to stabilize for then a proper DAIR or revision. Okay. Management should be via the infection MDT pathway as per BOST PJI guidelines. We've mentioned this in the previous episode, but you want sterile instrumentation, 5 sets of sample for MCNS and leukocyte esterases, and also consider a cynovascule, which is your test for alpha-1 defensin. And this is basically a point of care test for the joint fluid to test for this. And it's basically a peptide that's produced by neutrophils in joint infection. Okay. Plus or minus, you can also send it for fungal cultures, microbacterial cultures, and 2 sets for histology if it's a chronic infection. Again, I'm going to reiterate the point. So you consider a DAIR if it's within 6 weeks with modular implant liner exchange, and you have to check the kit is available in your prioritization station. This is where you do debridement, antibiotics, irrigation, and retention of the implant. It's contraindicated if there is a sinus tract, if there's a loose implant, if there is a fungal infection, or they have some complex MRSA or atypical infection. If it's longer than 6 weeks, you consider a revision. There's a first and second stage. If that fails, you consider a spacer or then further an amputation. In a 2-stage revision, the first is where you remove all the implants and place antibiotics impregnated cement plus IV antibiotic therapy. And you constantly check them with microbiology. I'm sure if you've worked in orthopedics, you have a patient on the ward who's been there for a long time, and they're constantly just giving antibiotics and checking with microbiology. So that's the kind of patient you are doing the first stage for. Once this is settled and the infection is eliminated, then new implants can be placed in a planned surgery. You have to submit data to the NJR and BJIR, which is the Bone and Joint Infection Registry. The niche points here that they might ask you, if you've got to here, you're doing really well. They may ask you, how can risk of prosthetic joint infections be reduced? Now, here it's important to structure your answers. So you want to, normally I break them down in patient factors and operative factors. Some people do pre-op, intra-op, and post-op as well. You can do that. So let's talk about patient factors. You want medical optimization, so diabetic control. You want cessation of smoking, steroids, immunosuppressive drugs, pre-op MRSA swabs. So an example is methotrexate. You check with the rheumatologist beforehand, you do your swabs, all that jazz. Operative factors can be broken down to pre-op, so antibiotics on induction, thorough and appropriate prepping and draping of the patient. Intraoperatively, you want to ensure there's laminar flow. You want to minimize traffic within the theatre. Post-operatively, you want ring-fenced orthopedic beds in cold elective sites, and you want an established infection MDT pathway within the hospital so that you target antibiotic therapy and review the patient in an MDT manner to ensure best patient outcomes. Okay? And that's kind of it for this station. I wish you well, and I'll see you in the next one.